Dr. Elena Frid, welcome to the Tick Bootcamp podcast.
Thank you so much, guys. Thanks for having me.
We're really excited to have you. I think our audience is really going to be excited to talk about this really important subject. And one of the first things I'd like you to react to before we get into your background is we think the most important element of a Lyme disease journey is the neurological, the psychoneurological, and the psychological element of Lyme disease, but it seems to be the least misunderstood. Give me your perspective on that observation before we even get into your background.
Well, I think all aspects of Lyme are important. I understand why you would make that comment. I think that it's probably the hardest thing for patients to experience and hard to treat because a lot of the times patients would have had symptoms for a long time and their symptoms escalate and then finally get to neurologic stage. And so patients have been suffering for a long time. It's hard to diagnose, it's hard to treat, and that's why I think there's a lot of kind of misconceptions around it.
Okay, well, that's a very nice politically correct answer to my first question. But let me challenge you, Dr. Frid, because we generally call the neurologists the superstars in the medical community because the central nervous system is the most important system, right? The central nervous system does control everything in your body. It controls what you sense, it controls what you perceive, it controls how you think, how you feel, how you act, it controls everything. It controls whether or not your immune system is going to be functioning, it controls whether your digestive system is going to function. So I appreciate the humility during the first question that I asked you, but let's just be honest, right? You really are you are trained and you treat the most important system in the human body, right?
I don't know. I have never thought of it that way. I obviously think what I'm doing is important. I've dedicated a long time to this field. Before NeuroLyme, in training and treating neurologic patients in general, and then subsequently already over 10 years, I would say 12, 13 years, doing primarily NeuroLyme patients. So I clearly think it's an important field. I'm not going to comment on whether I think it's the field or the most important field. I guess I'll leave it up to you and your audience.
All right, so I'll challenge you about that a little bit later, but I can already tell that your humility is going to serve you well with our audience. They certainly they really like humble people as opposed to folks like me. But we'll spend some more time challenging you on how important I believe, and again, maybe you'll disagree, maybe you'll agree, but I believe it is the most important system, and I believe if that system is impacted by Lyme disease, you are really in trouble. You really are in trouble if your central nervous system is impacted by Lyme, and unfortunately, all too often it does happen. So let's introduce the folks to you. They now know you're humble and you have a great deal of humility. So, talk to us about your background. Where are you from? I do detect a European accent.
Yes, I'm from Eastern Europe. I was born there and I immigrated to the United States in 1993. I actually did all of my training and schooling, undergrad, high school, junior high school, all in the United States. And I finished UMDNJ, Robert Wood Johnson Medical School in New Jersey, and did my training in New York, Northwell Healthcare System in neurology and then clinical neurophysiology. And then I came and opened an office in New York City, and very shortly after I started my own practice. I'm going to say within the first month or two of my practice, Dr. Raxlin, who happened to be, I'm sure your audience have heard of him, who happened to have an office close by, referred a patient to me for neurologic Lyme. And that kind of got my ball rolling into looking into ILADs and starting to learn more about what Lyme is, because I don't know if your audience know this or not. Maybe many of them do. realized that there's not a lot of Lyme discussion and Lyme training in medical school and in residency fellowship programs. So a lot of the physicians that patients call Lyme literate or call themselves Lyme literate, it's really things that they've learned post-training. So when they're already seeing patients on the field, going to organizations and lectures like ILADS, potentially listening to lectures like this, and kind of learning it by talking to colleagues and working with cases basically in their practice. So that's the way kind of I got started in the infectious Lyme world.
Well, Dr. Frid, I find it to be wild, right? I mean, you grew up in the Lyme Belt, right? You went to medical school in New Jersey. You were trained here on Long Island. And as an old guy who grew up on Long Island, I had been getting bitten by ticks as early as the 1970s. I mean, a big part of our lives, quite frankly, during my childhood, was walking in every day and doing tick checks. Yet, despite you spending, your formative, at least the formative elements of your career, both in medical school and your post medical training in the Lyme Belt, you were given no education or very little education about Lyme disease, and it wasn't until you came into the field that you started to learn about Lyme disease, and you had to pursue your educational training on your own.
Correct. I mean, that's exactly right. To be honest, I look back at some of the cases, you always have cases in your mind that you're seeing throughout your career. And there are certain cases in my residency and fellowship that now, in hindsight, I'm mortified as to how, we were taught to address these patients.
Yeah.
And unfortunately, it's an uphill battle because it's still, if physicians are interested in this, they still need to do a lot of legwork independently, because I'm not sure that a lot of the training programs have changed.
But Dr. Frid, so you must have seen thousands of patients during your residency and your fellowship, and you had no training on Lyme disease. And if you were treating patients on Long Island during those years, you had to be treating many, many people with Lyme disease, and you didn't have the tools to diagnose them.
Right. Correct. Agreed.
So let's now define the central nervous system for our audience, right? And I'm going to ask you, would you define the central nervous system as the brain, the spinal cord, the nerves, and the signals that go from your brain to your body and back?
So usually when we talk about the central nerve, when we talk about the nervous system in general, I divide it into two main categories: the central nervous system and the peripheral nervous system.
Okay.
The central nervous system consists of the brain and the spinal cord, and the peripheral nervous system consists of all your other nerves. And those nerves actually divided into three main categories: the motor nerves, which obviously make you move, the sensory nerves that make you feel, and then the autonomic nervous system. The autonomic nervous system is everything that we don't think we control, which is, for example, your breathing, your perspiration, your heartbeat, all of those things that we think are not under our control is actually controlled by the autonomic nervous system, which is part of the peripheral nervous system. And I talk about that because, again, a lot of people, it's not intuitive autonomic nervous system, but that's part of the neurological Lyme presentation that often happens to patients, and that part of the nervous system does get affected.
Okay. So I had argued when we first started our conversation, and you gave your humble answer that the central nervous system is the most important system in the body. And now I want to challenge you on that again, because of the way you've defined it is controlling everything in the human body. So do you want to be a little less humble now and agree with me that it does control everything in the human body?
It controls things, yeah, it controls things in the human body. The reason why I don't know that it's always the only thing that we need to look at or the number one thing, because of course there are complications of Lyme disease that are, severe, which are not part of the neurological nervous system, including cardiac issues that patients can have, nephrology, kidney problems, gastrointestinal, and of course, yes, often the neurologic symptoms are in there as well. So it would be unusual for a patient to have cardiac issues from Lyme and have no symptoms from a neurologic standpoint as well. They may not be as severe, but they'll probably still be there as well. So when we talk about, kind of chronic Lyme symptoms, very often you will have some symptoms from neurologic side. Whether there's how severe they are really depends on the patient.
Well, but Dr. Frid, and Matt and I want to dig into that with you, but there could be, you could have, I'll use your example. You could have cardiac symptoms as a result of having neurological Lyme, and the neurological Lyme having an impact on your autonomic nervous system, or you could have cardiac issues because you have the bacteria in your heart itself, right? So you could have the same organ having different causes of the difficulties with the organ, correct?
Absolutely, yes.
Okay, so now I want to talk to you and again, just give our folks a little bit more background on the central nervous system. One of the neuroscientists that I follow on his podcast argues that although it is a system that controls the entire human body, it is also a relatively simple system in what it does, and I actually outlined that for you in the beginning. And his argument is that the 5 functions of the central nervous system are your senses, perceptions, thoughts, feelings, actions. Would you agree with that assessment of the 5 things, general things that the central nervous system performs, or would you have a different perspective?
Yes, I would agree.
Okay, so now let's talk about sensing, right? Because I want to outline. We've now defined the most important system in the human body, even though you're pushing me back on that, and we've now defined the 5 things that it does. Now let's talk. Let's bring that together, and then we'll start to talk about Lyme disease and the different ways that Lyme disease can impact the central nervous system and what that could mean for folks, right? So now, what does sensing mean?
I mean, I'm not sure if you're talking about sensing from the perspective of like the feeling things on
Well,
your
no, I mean, it's the
skin.
whole thing, right? So we have at least, I mean, I think the argument is that we have 5 senses, or at least Aristotle argued that we have 5 senses, right? And it's the way that we ultimately communicate with the world, right? We have rays that come into our eyes, and we have sound waves that come
Right.
into our
So
ears.
you mean the 5 senses? Yeah, but there's also like of the sensory system. You check 5 parameters of the sensory system, so it gets divided into, and then we can go into the black hole of there's a 6th sense, and there's more senses than
Right.
we actually realize. But okay, yes, I
So
follow.
yeah, so you're much smarter than me. I want to say with the basics. So essentially, what the sensory element of the operation of our central nervous system is how we ultimately receive data from the world. Correct?
Right. Yes.
Okay. Now let's talk about perception, right? Because what ultimately happens in this black box of our brain is that the sensory data comes in, and then we create this image in our brain of what it is that we're interfacing with in the world, correct?
Correct.
Okay, because our brain is in the dark. Our brain doesn't see anything, right? It's just all of the sensory data that's coming into us, and then that sensory data is combined and ultimately becomes the perception. And the way I, for example, am perceiving this computer I'm looking at is different than the way you're perceiving this computer as you're looking at it, correct?
Correct. Yes.
And then after that, we have thoughts triggered, right? So all of our thinking is a part of this very important system, right?
Yes.
And then we of course we have our feelings. We're going to spend a lot of time talking about feelings, but our feelings are also triggered by the central nervous system. And then of course we have our actions, both our voluntary and involuntary actions, which you had already described for us, right?
Correct.
All right.
Yes.
So now if we have Lyme disease, and Lyme disease is in our central nervous system, and we're going to now build that out, it will impact what we perceive, correct?
Yes.
Actually, it'll impact what we sense, right? Whether we see something, hear something, feel something, taste something, smell something, it's going to impact literally how we sense the world.
Correct.
It's going to now impact how our brain ultimately brings all that data together and creates a perception in this dark space in our brain.
Yes.
And then it's going to affect how we think, how we feel, and how we act, right? Everything.
Yes.
All right.
Rich, are you trying to prove a point here that it is the most important part of Lyme disease? It's the most important topic. I'm sensing you're trying to prove a point here, Rich, is all I'm saying. So
what I'm trying to do is not prove a point, but because we have a wide spectrum of listeners, I think we really need to fully define the central nervous system so we understand how important Dr. Frid is and the work that she's doing on this journey, right? It's not again, and I've argued, Matt, quite frankly, that the most important and least understood element of a Lyme disease journey is the neurological element of the Lyme disease journey, right? And you know, and a subset of that neurological journey is the psychological element of the journey, right? So even though Dr. Frid is very kind and very polite and very humble, the truth is, you know, what she's doing here, in my view, is the most important work that needs to be done and the least understood, Matt. So, but if you want to follow up on that, Matt, with your questions, please do.
I certainly do. And I want to dive into the Lyme specific questions because most of our followers, Dr. Frid, are Lyme patients or family members of Lyme patients, the chronic Lyme community. And you had said something earlier that I feel like comes up often in the community where you said I think you said all Lyme patients deal with some type of neurological complications. Now, many people, I can tell you, I have a cousin, for example, who had, she calls it Lyme's, right? Which I know is a trigger for a lot of people in the community. She goes, "Oh, Matt, I had Lyme's disease too." But she never had neurological Lyme. She caught it at the early stages. She had some joint pain, maybe some flu-like symptoms, got some doxycycline, and moved on with her life. But to the best of our knowledge, she never had neurological symptoms. So right off the bat, Dr. Frid, can you help us explain the difference there? You know, acute Lyme, chronic Lyme, and what are your views towards somebody who has Lyme or Lyme's, as some people call it, which, you know, again, I'm teasing here, and people who then get debilitated with chronic Lyme, neurological Lyme, you know, autoimmune Lyme, all those types of things?
So I think that a lot of times, again, because there is potentially not enough training, potentially not good testing, potentially not, you know, the know-how in the community, in the medical community of kind of diagnose and treat and all those things. I think that some patients may have clinical symptoms and then they go misdiagnosed and their symptoms resolve either 100% or they resolve partially, but good enough where patients can go back to their day-to-day life. And so, and then months or years later, patient can have another insult with the tick infection. And so, where the one person may have had a strong immune system or had the one insult where their immune system was able to take care of it with doxycycline, without doxycycline, with some herbs, without herbs, and they're fine, the other person whose immune system may have been not as strong from the beginning, or they may have had multiple insults, and now the following insult, whichever one that is, second one, 20th one, you know, got them to a phase where their immune system is no longer able to take care of what's going on its own. And so then the patients develop what we call chronic symptoms with multiple organ system and multiple systems involved: cardiac system, neurologic system, dermatologic, skin manifestations. So you have this more of a systemic issue. And then your other question was, where does the autoimmune come into this? And the autoimmune comes into it probably pretty quickly, but for a lot of patients, if your immune system or if medications are able to take care of the infection, the immune system can calm down. There will be a subset of patients where, despite treating them appropriately, let's say they were diagnosed, they're treated appropriately, but despite all of that, their immune system is not able to calm down. And that's when the autoimmune is also something that needs to be looked at and treated at the same time, because just by treating the infection is no longer enough.
So I want to get back to the autoimmune component and also the treatment component, because we know at your clinic, Dr. Frid, or your practice, you have a wide variety of traditional and non-traditional treatments you offer patients that are beyond the scope of doxycycline or an antibiotic. But I want to focus on the neurological piece for now. So neurological Lyme disease can present differently in different people. And I think the hard part for me is I want to understand what your thoughts are regarding how Lyme can penetrate the brain and what that means. Because many people say, I have Lyme brain, I have brain fog, I have neurological damage, and I can't get better. Many people say I was completely bedbound and I couldn't even speak a sentence and I recovered. So I guess the first question I want to discuss with you pertaining neurological Lyme is it your experience that people, even that are really, really severely neurologically impaired, can rebound with proper treatment and therapies under your care?
Okay, so I do think that most cases, or a lot of cases, again, it's hard to know, you have to look case by case, but I do think that, let me back up. When a patient comes in and they talk about their clinical symptoms, one of the first things that I want to hear: do you have waxing and waning symptoms? Do you feel okay one day or good one day and bad the next day? And if that happens, to me, I want to hear about the good days, because that tells me that there's reversibility to the process. With that being said, it doesn't mean that a patient who has, 60 bad days in a row, and that's when they're coming in to see me, that that's it, they're going to stay like that for the rest of their life. That doesn't mean that. You have to start treating them, and you have to kind of see how they respond to treatment, and then you would be able to give them a better prognosis depending on how they're responding. But if off the bat they're having symptoms that are coming and going, to me that's reversible. To me, that yes, you can get to a place where things are gone. A patient who's been bad for 2 years, hasn't had a good day for 2 years, again, you have to start treating and see how they respond to treatment. And within 3 to 6 months, you'll probably have some idea of, can you get at least some of the symptoms down or reverse them completely.
So our listeners really love to learn why this is happening to them. So what is actually happening when the bacteria from Lyme disease and potentially other things from a tick bite and potentially other things that are opportunistic infect them and make them sick? What's actually happening to cause these neurological problems? Is it the bugs or the bacteria and the viruses in the brain? Is it an immune response that's causing neuroinflammation and encephalitis? Or is it a combination of different things causing different neurological symptoms with your Lyme patients?
I think, well, by the time patients come to me, it's a combination of things. It is the infection itself, it is the inflammation, it is the break in the blood-brain barrier, which allows other toxins, inflammatory cells, infectious processes to come into the brain where they should be kind of staying away at baseline. So it's a combination of things, and that's why, I don't talk about like there's one magic pill. because by the time you're having neurologic symptoms, it's usually multiple things that are going on, and you want to treat those things at the same time.
Right. But now the different presentation of these neurological symptoms, and you kind of described this. We did some research on you, Dr. Frid, and found some previous articles you wrote where you talk about, headaches and migraines. You can have neuropsychiatric symptoms, so behavioral issues that are neurological potentially, neurodegenerative disorders. You can have the impaired speech. You can have the Bell's palsy, right? All different presentations. And in the end, all of these things are being caused by Lyme or other pathogens, you believe, correct or no?
Right. So to go back to what we talked about earlier in terms of what kind of got me into Lyme disease is when a patient, for example, comes in, and a lot of times I do get patients from psychiatry because they'll present psychiatrically, they've been to their primary care, they're sent to psychiatrist. Psychiatrist, this is the key, has tried multiple different medications for them, and nothing's making them feel better, and it's often enough makes them feel worse. That is unusual. I'm going to say 80% of patients who go to a psychiatrist for mood disorder or thought disorder will get better with the agents that are provided to them by the psychiatrist. Maybe they're not 100% better, but they will start seeing, they're less depressed, they're less anxious, and they're able to function better. But those patients who are refractory, those are the patients that I concentrate on because to me, it seems like they have an underlying condition, perhaps infectious, inflammatory, autoimmune, that's actually triggering their psychiatric disorder. So it's not a pure psychiatric disorder. It is a medical problem that is manifesting as a psychiatric illness. And so in conditions, and that goes for headaches, for example, as well. So if somebody is having intractable headaches, most patients feel better with one or two anti-headache medications. But if you're having intractable headaches, that's something that is worth looking into, or intractable nerve pain. That is something worth looking into. Is there a systemic problem that's actually triggering and causing my underlying medical condition? And that's when I think a workup would be important to look, do I live in an endemic area? Do I practice any high-risk behavior, hunting, golfing, any of those things? Have I had a zillion tick bites when I was a kid, and then I had another insult that happened, let's say elective surgery, and now my pain is out of control? So those are kind of like parts of the history that I listen to see, is infectious autoimmune etiology part of the clinical picture.
Dr. Frid, you and Matt talked a little bit about the blood-brain barrier, and we do have a diverse spectrum of people listening to this podcast. So can you give us a description of what the blood-brain barrier is and how these microbes do cross the blood-brain barrier to get into the central nervous system?
Yeah, so blood-brain barrier is part of a protective mechanism that the brain has. It's actually an anatomical structure that is microscopic. I describe it to my patient as if you imagine that your brain sits in a plastic bag, and the plastic bag is there to protect from microscopic chemicals and compounds to enter the brain at will. So they're supposed to enter the brain only if they kind of meet a certain criteria, right? So there's like gates, and they have to meet certain criteria if they can enter the brain. And the brain wants things like nutrients, oxygen, things that basically benefit the brain. When you have a break in the blood-brain barrier, which means like you have a hole in that bag, there's areas of the brain where those chemicals that are not beneficial to the brain can enter at will. And so those can be infections, they could be inflammatory cells, they could be prostaglandins, things that like are allergens. And so those are the things that basically make the brain feel bruised. And so it's not functioning properly. There's inflammation in the brain. And that's what I mean when I talk about break in the blood-brain barrier. Interestingly, that part of the brain can be healed when you take away the substance that caused the break. So if that was the infection that caused the break, then taking away the infection will allow the blood-brain barrier to heal.
So, Dr. Frid, is there something unique about the combination of germs that we call Lyme disease that makes it so that it can break down this bag that's surrounding the brain?
I mean, that's a question that's been kind of talked about in the Lyme community. It's probably the fact that it can evade the immune system and trigger our inflammatory cells to kind of constantly be active. So that's probably part of the combination of the fact that it's evading the immune system, it can have a chronic form, and the fact that it can cause constant inflammation. That's probably what's doing it.
So let's talk about this crossover. I know Matt has some follow-up questions, but I just want to say with this one line that we're starting. So the central nervous system does control the immune system, right? It determines whether the immune system is going to be functioning or it's not going to be functional, or how it's going to be functioning, right? And what's happening is these germs are overwhelming the immune system, which then makes the blood-brain barrier more porous. It gets over into the brain, and then when it gets into the brain and it causes inflammation, it then weakens the immune system on the back end, because the brain is no longer able to function as efficiently in sending signals to the immune system.
Correct, yes.
And it just becomes this really vicious cycle where the protective tools that we have, whether it be the immune system or the blood-brain barrier or any of these other natural protections that we have, they just break them down one system at a time.
Right.
So I want to circle back, because we talked about a lot of these neurological things. And for me, the next question I had in this same line of topic is, we hear all the time that people get misdiagnosed with things like autism, Alzheimer's, multiple sclerosis, dementia, Parkinson's disease, etc. And then it turns out to be Lyme disease, right? In fact, we've published often about people who have had this scenario, like Chris Christopherson, who thought he had Alzheimer's disease, but it was Lyme disease, right? So in these cases, Dr. Frid, you think there is a subset or potentially a large portion of these other disease communities that are really suffering from Lyme and could get relief, because many of these things are considered to be really incurable, right? So what are your thoughts on that, with these other misdiagnoses and potentially having relief for people that think there is no solution or no help for them at all?
Well, I think that there are published articles, not specifically about Lyme disease, how, for example, for Parkinson's disease, people are looking into infectious etiologies and autoimmune etiologies. For MS, for a long time, you look at, they've been looking at infectious etiologies. They can't necessarily identify a specific infection, and that could be because, right, we don't have a very sensitive testing for Lyme. So and then as you said before, Rich, when we talk about Lyme, we do talk about, or at least I talk about, not just Lyme, but the co-infections as well, that I don't think we mentioned. I can say a few: Babesia, Bartonella, Ehrlichia, Rickettsia, even Mycoplasma goes in there. Strep could go in there. So kind of a combination of infections. Not all of them are necessarily tick-borne, but some that kind of can trigger your immune system and cause these autoimmune inflammatory conditions. So that's definitely, kind of part of it.
Yeah, I just feel like there needs to be more research there, because we had Dr. Alan McDonald, another ILADS doctor, on, who's now retired but still doing his research, and he's done some really cool research to prove, dementia, Alzheimer's, and even some cancers being connected to Lyme disease and co-infections. And when we say Lyme, we mean Lyme. Dr. Phillips calls it Lyme plus. When we say Lyme, we mean all the co-infections that could come along with the tick bite. Now, The other
Wait a minute,
part.
now, why don't we ask Dr. Frid about our definition of Lyme disease and see what her reaction to it is?
I think you should do that, Rich,
All
because
right,
I love listening to you ask people this question.
So Dr. Frid, one of the things we always do on our podcast is ask people whether or not they like our definition of Lyme disease. And it is kind of odd that two geeks who run a podcast would feel like they have the right to come up with a definition of Lyme disease. But the reason we do is because there seems to be a disease without a definition, right? That almost every single person we talk to seems to have their own definition for Lyme disease. So we said, well, why don't we take control of this definition? So here, we're going to give you ours, right? So we define Lyme disease as a polymicrobial, multisystemic, chronic infectious disease. What would your reaction be to that definition?
I think it's good. I mean, I don't like the Lyme as the title. I like the definition. I think it should be renamed, right? Because I think Lyme is a specific, infection. Borrelia burgdorferi has a scientific name, and so because we're talking about it in kind of a multi-step, multi-dimensional way, it should probably be renamed. But I like the definition for sure.
I mean, you're very much in the Dr. McDonald arena. Dr. McDonald actually wrote a really famous article for LymeDisease.org entitled "We Need to Divorce from Lyme." And his argument is that using the term is causing more harm than good. And it's hard to disagree with smart people like you and Dr. McDonald. We really should divorce from the term. I think the challenge with that is, and we've debated that issue as well, is that so many social and medical organizations and so much training is built around this term that it would be really hard to divorce from it. But I agree with you, right? It is really a challenge when we're in this position where we're debating, is this acute disease? Is it a chronic disease? Is it one bacteria? Is it multibacteria? So we've said we're going to take control of that. We're redefining Lyme rather than divorcing from it, and we're gonna make sure that we focus on this polymicrobial nature, which I think is really important. And I do have a follow-up question on that, Matt, if I may. See, we both love you so much already. We don't want to let the other guy ask questions. But Dr. Frid, are there some germs, coming back to the blood-brain barrier, that are more aggressive, or in combination with some of the again, we have a whole bunch of germs that is being spit into us by the tick or ticks that have bitten us. We have all these other germs that we've picked up over the course of our lives that our immune system is managing, and then they all come together and they attack us, right? In some way. Are there some tick diseases that are more aggressive and make it more likely that the blood-brain barrier is going to be pierced than other germs, or is it really just this combination?
Yeah, and I mean, it really depends on the organism, right, that the germs are attacking. So the patient themselves, what's the integrity of their immune system? We also talk a lot about Bartonella Hensley causing a lot of neuropsychiatric,
I was just going to get to that.
Yeah, so that's a common one that a lot of patients struggle with in the sense of when we talk about neuropsychiatric issues and neurologic issues, Bartonella often comes up.
So we often hear about Bart rage, and the reason I was getting to that, you anticipated my question, but the reason I was going there is I'm just wondering whether Bartonella, there's something unique about Bartonella that allows this now combination of germs to pass the blood-brain barrier, and maybe that one bacteria in particular is more dangerous than others when it comes to the protection that you described so beautifully as this bag around the brain.
Right. I mean, I'm not sure what is it about Bartonella Hensley. I know that, looking into it, we actually treated, I don't know if your patients know it or not, but we treated with the same medications that you treat tuberculosis. So, and tuberculosis by definition is a chronic infectious disease, which in fact, that just one bacteria typically gets treated for 9 months with 4 agents. So and we basically take that model and apply portion of that model into treating Bartonella. So I think that aspect of it, again, the chronicity of it, the fact that it can evade the immune system, the fact that it's not treated right away, because as you said, a lot of patients go for many months or even years before they get to physicians who diagnose them with it and start treating. So I think maybe that aspect of it is what's causing like the neuropsychiatric part. The other thing, which we sort of didn't touch on, but I think is an important point, and again, this is the theory as to why some people develop autoimmune conditions, and I'm bringing it up here because I think part of this could be the rage, could be autoimmune encephalitis, which is a big term for some of the things that people experience, and rage could certainly fall into that. And the thought is that perhaps the bugs, right, infections have been around for millions of years before we have come. So the thought is that these infections incorporate into our DNA, and for a patient who is exposed to an infection that's very similar to their DNA may develop an autoimmune condition. And so that autoimmune condition is another thing outside of just the infection and the inflammation, may be targeting your brain because you may look part of your DNA looks similar to that bug. And that's why the same infection may present as X in one patient and as Y in another patient. So that's kind of the heterogeneity of these conditions also causes a problem with diagnosis.
Let's bring it all together, right? Because the infection is one part of it, as you noted. The other part of it is inflammation, which generally inflammation comes along with the infection and the bug. But the autoimmunity part, I think, is something I want to define a little bit better here. Because the autoimmunity part is essentially what our bodies have a built-in system to protect us, which is our immune system. If we come into contact with something that's bad, our immune system will respond and eliminate it so we don't get sick. Or if we get sick, our immune system helps us overcome that illness. But when our immune system goes haywire, it essentially attacks good things in the body, not just bad. And at its core, I know I'm really oversimplifying. Isn't that what autoimmunity is? When your immune system is really attacking the good parts of your body and making you sick, rather than attacking the bad things to keep you healthy.
Right. I use that analogy. I use analogy of army. So the immune system is your soldiers, and at some point in the case of an autoimmune condition, your soldiers cannot differentiate between the bad guys and the civilians, and they basically try to kill off everyone, or they go after anyone. And so then it looks like it's looting, right? So you're then destroying parts of your community that are vile, and that's what's basically causing an autoimmune condition. And autoimmune conditions are not just neurologic. There's many ones that people know. There's Hashimoto's for thyroid, there's lupus for joints, and that's where, and we name them based on where the immune system is attacking. So in the case of encephalitis, it's attacking your brain, so that's the type of autoimmune condition that is. In the case of Hashimoto's, it's attacking your thyroid. So it's just named based on the organ system that it attacks, but the mechanism of action is the same. Your immune system is attacking yourself.
Right. But if you have Borrelia or other things, right, what we call Lyme disease, Borrelia burgdorferi, and other things in your brain, your immune system may be responding to the bugs in your brain, but as a byproduct creating inflammation. And that's not really autoimmunity, because once you rid your brain of the bug, it should subside.
Yes.
It's when the immune system keeps attacking the brain post-infection when that becomes autoimmunity, correct?
That is correct, yes.
So I think the immune system is a really important theme here. We had Dr. Baumgart on from Johns Hopkins, and she was sharing with us some really interesting research she's been working on. And she shared that Lyme has been proven to destroy parts of the immune system. Now, she's really smart, so I'm gonna, if I say something wrong, you can correct me, because I'm sure you understand this, Dr. Frid, way better than we do. but you talked about Lyme, and I'll quote her, obliterating lymph nodes, which are parts of the immune system, right? So if your immune system is designed to help you, and when it's functioning properly, it's supposed to be killing the Lyme bacteria, which is the bad stuff, but Lyme is destroying parts of your immune system, you're less likely to overcome it with your immune system by itself if you are in a late stage chronic or undiagnosed part of Lyme disease because of what it's doing to your immune system to survive in your body, right? I think it's a kind of like that double-edged sword there.
Correct.
So the question is, people that feel like they have depleted immune systems, in your experience, can these immune systems rebound? Because in my experience, I feel the answer is 100% yes, right? I had a really obliterated immune system, and I feel I was able to build it back. But we don't want to scare people. We want to give them hope. So when it comes to those kind of things, A, can we decrease the pathogens, and B, can we rebuild our immune system?
Yes, we can. Interestingly, certain neurologic conditions, if you diagnose somebody, you think this is something that they need to, be treating for life. But in the case of Lyme co-infections, when that's the trigger of a particular neurologic condition, interestingly, patients don't need this treatment for life, right? They can have it for 6 months, a year or two, and then they back off. I'll give an example. So there are patients who, for example, have a low immune system that is defined by low, for example, immunoglobulin levels. And usually if that happens, that's something, immunoglobulins are those soldiers that we talked about that fight off infections. And usually if patients have low immunoglobulins, not in the setting of Lyme, it's usually something that's an ongoing thing. Like their body doesn't recover. They continuously need to take immunoglobulin treatment, which is an IV infusion. In a setting of when this happens in an infectious setting like Lyme plus, those patients will take immunoglobulins plus treat their infections for, let's say, 6 months or a year, and then their immunoglobulins recover. So they don't need to take the treatment, the IV treatment every month. They can come off it. So yes, I agree with you that there is reversibility there. And for some patients, there's reversibility just by treating the infection, and that's enough. They don't need to treat the immune part of it. And for other patients, if just by treating the infection, it's not taking care of the problem, then you layer in treating the autoimmune, treating the low immune system, the autoimmune part, and then a lot of times that shuts down the mechanism and they recover as well.
So when reading up on you, Dr. Frid, we read that you really have to address concurrent conditions in your chronic severe patients. And it's what you just said. There's the infectious, the inflammatory, and the autoimmune component. And I couldn't help but think of Dr. Armin Schwartzbach, who's the founder of Armin Labs over in Germany, who we had on the podcast. And he said the same thing. In fact, I'm going to give a teaser. He did a Lyme hack for us in May, and his little teaser video touches on this again, and he stressed it on the podcast. He feels to overcome Lyme, chronic Lyme, Lyme plus, as you called it earlier, you need to address the 3 I's. So he keeps saying the 3 I's, which are infection, immune dysfunction, and inflammation. So it sounds like you're very much in sync with many other Lyme litter doctors, where that's kind of the trio that has to be addressed to holistically and full body help your body heal and overcome the severe illness.
Agreed. Yes.
So interesting question here, because you highlighted your views, I believe, towards autoimmunity and some of these other conditions. Now, we've had some doctors and researchers come on and say, we believe that all autoimmunity has an underlying, pathogenic root cause. We believe that all psychiatric conditions have an underlying pathogenic root cause. Maybe not all Lyme disease. Well, they argue that it's not. Lyme is a part of it, but there are other pathogens, other viruses, other bacteria, other protozoa, other fungus, you name it, that are causing these mental health issues that are so apparent in today's world. Now, it sounds like you're kind of in the middle. You don't think every mental health condition, you don't think that every autoimmune condition is related to a pathogen, but you think some are. Is that your stance in this topic? Not to put you on the spot or anything, Dr. Frid.
That's what we do.
I think that it's worth exploring. Okay. When I was in medical school, it was my first year in medical school, My histology professor stood on the stage in front of our class of like 200 plus people and said, I can cure any disease, but will the patient survive it?
That's
You
funny.
know, you could take a blowtorch and cure any disease, but will the patient survive it? So and I understand that stance, and it is very possible that, you know, the science and medicine hasn't caught up to everything that's out there, and there must be a trigger for things. You know, if patients are born healthy and then they develop certain conditions, psychiatric, etc., that it could be triggered by something, infectious or, you know, otherwise. But my point is, if someone's condition, let's say if somebody has mild depression and they are taking you know, your bread and butter psychiatric medication, a small dose, and they're doing great, you know, and for example, you're recommending 1 year or indefinite amount of antibiotic use, which can affect their gut and microbiome and all this other things, that also is not an easy treatment. What do we do with that patient? So when you're talking about research and when you're talking about clinical practice, it's two different things. The patient's headspace needs to be there. You need to be committed as a clinician to work with them because they may have, you know, complications from the treatment that you're prescribing. And obviously, you know, you don't want to make them feel sicker than they are. If a small amount of herbal medication or prescription medication will help their mood versus they're on 3 antibiotics for 2 years and causing gut issues and etc., you know, what do you do for these patients? So I appreciate the comment that everything is caused from infections, and we may not know which infections are actually causing things. I don't know if I agree 1,000% with that statement. I understand where the statement is coming from, and I certainly understand it, especially in patients whose symptoms are intractable, where they should be helped by a particular medication. You could try one or two, three different agents in the category, but if it's making them feel worse, they're not better at all, I would definitely look for other causes.
Yeah, I feel like it's an important distinguishment that I didn't really think about until you brought it up, which is research versus clinical practice. And I think you're right. You know, your colleague in Manhattan, Leo Shea III, who's an ILADS neuropsychologist we had on the podcast, he's the one who's put that thought in our head first, saying every single psychological condition I treat, I believe has an underlying pathogenic root cause. But to your point, if you can't easily identify what that one or those pathogens are, you want to work towards getting your patient symptom relief. So your goal as a clinician is to help get them symptom relief and help them be healthy and not be giving them drugs that are these carpet bombs to figure out what's going on and destroying their system. And that's why you mentioned maybe alternatively some herbs could be good because they're a little more gentle, right? And I think that makes sense. But I want to bring you back to your topic about, you know, same thing, right? Autoimmune and all that kind of stuff, because the same is true with autoimmunity. We've had people come on here and say, I had 12 different diagnosed autoimmune conditions and I treated the Lyme and I cured them all. Now, it's that same idea, right? Is all autoimmunity tied to a pathogen or not? But this is where I feel like genetics comes into play, and I'm curious what your thoughts are on what you do in your practice, because we had Bob Miller, who's a naturopath and geneticist, on, and he talked to us about some really cool tests that he's created and things that he does with his patients to identify just things that they may have a little off in their genes, and then providing really simple things like dietary supplements, lifestyle changes to help offset or overcome those genetics, so you're less susceptible to develop the autoimmune triggers or predispositions in your genetics. So is that something you consider in your practice, genetics tied to autoimmunity, potentially making Lyme and other co-infections worse in some of your patients?
Uh, yes, I like when my patients kind of have integrative docs who can help with that aspect of it for sure. Certainly, I'm going to say, for example, diet modifications and supplements. I think, I mean, that's important. I would say that if if within a reasonable amount of time, for example, diet modification, I'll say 2 to 4 weeks. If you're, a completely clean diet, are you starting to see some improvement? If that's the case, continue. I think we're on the right path. If, for example, patient feels nothing, I don't think 6 months of that same diet is going to change a lot for them. So I do think that those things, I'd like to see results pretty quickly. Is it healthier to, kind of watch your diet and eat clean? And if you're deficient in certain vitamins and supplements, to take them? Absolutely. But again, I'm working from the perspective of a clinician, so I want to hear, are their symptoms better? And usually if I implement a particular treatment, I want to hear that they're feeling better within 2 to 3 months. So, and if they don't, I want to change things up for them.
The time frame is key there, because you mentioned earlier with tuberculosis, the antibiotic treatment is 9 months. And one of the things that we read about you is you feel we need to get more awareness out there to advocate for proactive, extended treatment protocols for chronic Lyme disease. So what does that mean to you? Because I'm, everybody who listens to this podcast knows I'm sort of this middle ground, half Western, half Eastern, where I love herbs, but I also believe there's certainly a time and place for antibiotics in Western medicine. But I also just think, to your point, 9 months or a year of antibiotics has a ton of downstream effects as well on your body. So where do you land, and what generally do you do to treat your patients? And how do you, if you do use antibiotics, how do you overcome some of the damage being done with other tools? And what are those tools?
Mm-hmm. So I usually, there's no arbitrary number of days, weeks, months, or years that I tell patients that they need to be on a particular treatment. I would say I do recommend, if you're committed to a particular treatment, if someone is able to tolerate it, I would recommend them to take it for at least 2 months and see how they feel. If you're starting to chip away, it doesn't mean that in 2 months' time you go from being bedbound to, running a marathon. But if you're starting to see that your symptoms are getting better, that means I would continue that same treatment. If 2 months later I'm hearing that, I was getting better at first, but for the last 2 months I don't feel any different, that means I want to change things up for them and see if we can look for, is there another infection that we didn't address? Is there an autoimmune issue that we didn't address? Is there mast cell? What else is going on that can be kind of holding us back? So I generally say that majority of patients, especially with chronic symptoms, need to be treated for an average 1 to 3 years. What that looks like in terms of how aggressive they are, how aggressive you get with them, it really depends on how they are responding to treatment. And interestingly, a lot of times you would think, even with little kids or adults, they're having, let's say, gut issues, or they can't tolerate things, or they feel anxious all the time. And interestingly, you're like adding 2, 3 agents for them, and you think, are they going to be able to tolerate? And a lot of times when they need the medication, they can tolerate it. And I don't know, if it's not a scientific thing. It's like a human thing, an instinct thing, that when they need the medicine, they're able to tolerate it. And a lot of times what happens is their symptoms get better. So what I'm saying is, within 2 months, you want to start seeing some improvement. It doesn't mean that they're ready to come off medication, but you want to see kind of incremental improvements.
So you mentioned mast cell, and to me, mast cells very much, histamine, inflammation, very much related to allergies and potentially autoimmune as well. So how is mast cell activation syndrome? We hear this a lot in the Lyme community. MCAS, mast cell activation syndrome. I have hives. I can't eat certain foods. I'm super sensitive to everything, to, environmental things, food-driven things. Is that related to Lyme? And is it related to the immune system? Like, how do you categorize mast cell activation syndrome in relation to everything else we've discussed so far?
So it's important in my practice in the sense where the patient who, and what you mentioned is correct with all of the allergic type presentation, but also the patient who, let's say you give them innocently one or half a dose of an antibiotic or half a dose of a particular treatment protocol that you're starting, and they have the worst kind of reaction to it. So they're basically reacting to things that normally they would be able to tolerate, or your bread and butter patient would be able to tolerate, but they have an absurd reaction to it. So that means that aspect of it needs to be addressed, because it's not going to allow you to move to actually treating the underlying issue for them. So as we talked about before, it's kind of a circle, a closed circle, where you can't treat one without the other. And that's where kind of the holistic approach, from the perspective of you treat them from all angles to get rid of the issue. And it's really not just one issue, because as you mentioned, the mast cell can be triggered by the infections. And the mast cells, interestingly, live by the blood-brain barrier. So all of those histamines, prostaglandins, inflammatory interleukins, they break the blood-brain barrier and enter there and cause more inflammation. So it's a closed loop that needs to be addressed.
So MCAS is often discussed, and we get a lot of questions about it. People that can't tolerate treatment because they're so sensitive. What are some tools that you use to treat your patients or help them address MCAS before being able to tolerate maybe an herbal antimicrobial or an antibiotic? Because first, you noted you have to get their MCAS under control before they can do anything because they're so sensitive. So what are some tools that you use to help with that?
Right. So I don't treat MCAS on its own. I do like an allergist on board. To start with, I do like them to use antihistamines. A lot of them are available over the counter. So there's H1 and H2 blockers, things that affect the upper airway and then the gut. And so those things can be taken like Pepcid, Benadryl, Zyrtec. There's obviously prescription H2 blockers. There's herbal medications like quercetin that are mast cell stabilizers. So all of those things, you basically get them on board to start being able to tolerate some treatment, and you start very slow. That's another way to do it. So where on an average you would start maybe a full dose and then layer in the next medication a week later, or at least that's what I do. With these patients, what I would do is I start with a quarter dose, and we go very, very slow to see what they can tolerate, in addition to taking the histamine blockers. That's the way I'm addressing this. There's other, I've used in the past exosomes and stem cells for patients with mast cell activation, small doses, which helps to, again, reduce inflammation for patients and drive the inflammatory arm of the immune system down. And it doesn't cure their underlying condition, but it helps to control their mast cells. And so then they're able to tolerate treatment. So I've done that before as well.
Yeah, what's interesting there is, Rich, I think you wanted to jump in and probably say the same thing I'm going to say, so I'll let you jump in and ask it.
Oh, no, go ahead. Go ahead.
So what's interesting there is we've heard something similar but a little bit different, and I want to just ask you that specifically because we've heard from other people that exosomes are very helpful for people that have MCAS and are more histamine intolerant, sensitive, and that's why exosomes are a little bit better for those groupings of people. But we've heard that stem cells specifically are extremely pro-inflammatory as they're working, and they may not be a good tool for people that are, MCAS or histamine, prone. So are you arguing that stem cells and exosomes are both a good tool for people that have inflammation?
I use mainly exosomes, and I use a little bit, a small dose of stem cells for these patients. Again, they're getting baby doses because they're so inflamed. But I do hear the point. So we use a small amount of stem cells. Mainly you use exosomes to bring down the inflammatory process.
So, Dr. Frid, I want to bring us back to the central nervous system again. You know, the most important system. And yes, I'm going to continue to tease you about that. One of the things that we hear in the community is that oral antibiotics are not effective if you have neurological Lyme. Can you give me your perspective, or give us your perspective on whether or not oral antibiotics have limitations in their effectiveness when someone is dealing with neurological Lyme?
Honestly, I would say majority of my patients, I recommend to be on oral medications because I do think that they're effective. There is a small subset of patients that will be on IV, but I would say that's a minority in my practice because I do think that the oral medications are quite effective. And again, that could be that we're closing the blood-brain barrier because we're lowering the amount of infection that's around. That's another thing we didn't talk about, but I think it's important to touch on in terms of, do we control the infection or do we cure the infection? And my answer to that is it really doesn't matter because I think of it as, I mean, we live in a world where we're exposed to bugs hundreds of times a day, and I may be conservative on that. Okay? So we do have ways, mechanisms that we're protecting ourselves from that infection, those infections, those bugs actually becoming an illness for us. So even if we have some percentage of infection that's still left over, that's not cured completely because of biofilm, or it's not there because it's living in an area where the immune system can't get to, it's evading the immune system, all of that, I don't think it's that important. I think what's important is to get down the large amount of the infection so then your immune system can take over and keep that infection caged up, because we know this mechanism of action in, for example, herpes simplex virus, that if you have it, it's always there, but it doesn't mean that you're distraught about it, 24 hours a day, 7 days a week. Yes, sometimes you may have an outbreak if your immune system is a little bit lower, but largely it's under control. So if we can get to that point, especially for severely chronically ill patients, I think that's okay. And again, that's a conversation that you have with the patient. Well, how have you been? And that's another thing I also ask about. When a patient is kind of on the tail end of the treatment, I ask, do you have exacerbation of symptoms if you have an insult to your immune system, which is a common cold, stress at home or at work, elective surgical procedures, anything like that. Does that make your symptoms flare? And if it doesn't, that tells me that their immune system is really recovering. And if it does, it's a marker to say, look, you need to still be treated. So those are the things. I don't know that it's in every single patient, is it feasible to 100% eradicate these infections, or can we coexist with them in a sense where my own immune system is going to put you in jail and you're going to stay there and I'm going to live my life?
So I think one of the things folks don't recognize, Dr. Frid, is we're actually more bug than we are us, right? That we actually, when looking at all of the microbes that we have in our body, there are actually more microbes than there are non-microbes in our bodies, right? So it really is all about immune homeostasis, and really what's happening when we're becoming chronically ill is that we're out of homeostasis.
Right.
So let's talk a little bit more about antibiotics, right? Now, we've been told by some of our past guests that 70% of the immune system is in the gut. And one of the things we also know is that when we're using antibiotics, it is going to have a negative impact on our microbiome, on our gut. So how do you balance the use of antibiotics, especially long-term antibiotics, with the impact that it's having on your gut health, and of course the consequence that that's having on your immune health?
Um, so I'll use another little anecdote that I learned when I was in residency. When I had my attending um, teach me during a case, which had nothing to do with Lyme. It was a completely different case. But the issue was if I give a patient this drug, this may happen, but there. Okay, so let me back up. So it was a patient with a brain tumor, and the brain tumor was bleeding. The patient was in the ICU, and we needed to decide what do we do. We need to give her medication so she doesn't get a blood clot because she may have complications from the blood clot in her legs. And so he told me, you can't treat the what ifs, you have to treat what's in front of you. So that's how I basically address the patients. When a patient comes in and I see that they have all of these infections, they have never tried antibiotics or were maybe on one antibiotic for 10 days and we don't know how they reacted, I need to treat what's in front of me. I can't today worry about the what if. Going forward to see if the patient's responding properly to treatment, they're tolerating everything, and I feel like they're continuing to improve on a particular treatment that I'm giving them. Obviously, I try to have them take probiotics, probiotic-rich food. I also like when they alternate probiotics. I think that's good, not to be on the same one ongoing, but change things up. Taking, if possible, taking their medications with food. Certain medications, I get it, need to be on an empty stomach, but as much as possible, taking things with food. And then, if possible, if they're responding to a particular treatment that we're doing, trying to simplify their drug regimen. So if we can, where I do, I understand that taking supplements and vitamins and all of this is super important. But again, compartmentalizing and deciding, look, if they're taking a zillion things, I'm not sure what's making them feel sick. I know that my top choice is like this Bartonella and Lyme is an issue. Let me focus on that for a little bit and then layer in the other things so they're not taking 20 medications twice a day and just kind of focus, hone in on the main things. So that's how I address it. Obviously, every case is different. Some patients cannot tolerate medications orally. That is when we talk about intramuscular or IV medications. That would be a case there to try to bypass their gut. And of course, if they're helped with herbal medications, then we either do a combination of herbs and antibiotics, or even I usually end with herbs. So if the patient feels like, oh, I'm feeling better, I say, okay, well, let's stop the antibiotics and just do the herbs for a couple of months. And if you're still good, then we'll back off. So that's usually my clinical practice. If they can start with antibiotics, we start with that and kind of sort of weave out of the antibiotics through herbs and then off.
So are there some antibiotics that you think are better than other antibiotics for neurological Lyme, right? Because one of the things that, that I think concern folks in this community is that there's an overuse of broad spectrum antibiotics. And I think at the acute phase, a broad spectrum antibiotic like doxycycline is a great tool. And I recently took doxycycline myself, so I'm not anti-antibiotic. But I do think there is an overuse, especially of these broad spectrum antibiotics. I'm wondering if you use some antibiotics versus others in treating people who have neurological Lyme.
So interestingly, for neurological Lyme, and it's not just me. I mean, there are studies out of Hopkins, I think, that were published a number of years ago saying that it's better to treat in combination. So monotherapy just by itself doesn't work. It's a combination treatment, and then by definition, that's going to be broad spectrum. But in that case, again, I'll use broad spectrum. I'll use 2 herbs and 1 antibiotic because a patient can't tolerate just antibiotics. So it really, again, patient dependent. But I think if we're just talking about, let's say, antimicrobial treatment, using combination treatment, whether it is a number of antibiotics or antibiotic and herb or a number of herbs together, but just a combination that works in a slightly different way is the way to address the complex neurologic Lyme presentation. But I do have to say one thing, and I don't know your specific view on it, but in my clinical experience, for patients who have mast cell, it should be careful with herbs. And I still use herbs in them, but I don't use the herbs that are the combination herbs that have like 7 or 12 ingredients in them. I do one ingredient at a time. Because they have mast cell, you need to be careful and try to use kind of the single compound at a time.
Why is that, Dr. Frid?
Well, because they can have a reaction. We don't know what they're sensitive to. So it's a higher chance if you're using an herbal that has a bunch of different ingredients, you don't know what they may react to.
Got it. So on the topic of treatments, one of the things that we read up on you that we were very interested by was your featuring of hormone therapy and hormone treatment on your website. So we had Dr. Ken Holtorf and Moses Laufer on the podcast, over the last year. And both of them, obviously both from Holtorf Medical Center in California, but they both advocated for bioidentical hormone therapy and said it's something they do in most of their chronic Lyme patients. And then we have other doctors who say, I'm not really sure that's the best idea. So where do you land on this, and what specifically do you help with hormones? Because many of us in the Lyme community, when we're in the throes of it, we feel like our hormones are just completely haywire. We're in constant fight or flight. Our nervous system is overwhelmed. We have, probably, an imbalanced hormone set up in our body. So I'm curious what your approach is when it comes to hormone treatment as you treat your patients.
Okay, thank you. I don't treat a ton of hormone issues, meaning like, for example, low testosterone, estrogen, progesterone, although I do think that for some patients that is an issue, especially for a lot of women, overproduction of estrogen, which then they could, also can make you feel very emotional, wired, ragey. And for men, low testosterone levels could cause fatigue, brain fog, things like that. If I do check for that, and if that is something that's an issue, I would generally refer them to probably an integrative clinician. In terms of thyroid, I think thyroid is a significant issue for many patients. And that's, again, often is undertreated. As you know, a lot of patients struggle with fatigue. For women, that's a very important hormone. For men too, but I think for women, thyroid is a big hormone for them, probably even more than estrogen, progesterone. And for men, testosterone is the #1 hormone. So in terms of bioidentical, agreed with bioidentical. I've attended a number of lectures with Dr. Rouzier. I believe he's out of Utah. So he's a big proponent of bioidentical hormone replacement. And that's not even, he's not a Lyme literate doctor. He's just talking, I almost think that the hormone piece of this is as controversial as the whole Lyme and co-infection aspect of it. And I think the synthetic hormones is a problem, and they're not, and they are viewed as, and are talked about as if they cause the same issues or problems as the bioidentical hormone. And my understanding after sitting over 50 hours of lecture with Dr. Rouzier is that that's not the case. And that the bioidentical hormone are preferred because that's kind of more natural to us. And again, we have some arbitrary numbers that define that you need to have this much thyroid medicine or this much testosterone, and in reality, you know, people are different, and you need to kind of figure out and feel, you know, what's their complaint. If a you know, 40-year-old athlete, a college athlete comes to you versus an 80-year-old, you know, older gentleman comes to you, their testosterone levels should not be the same, you know, in that same range. So it's definitely the art of medicine that's trying to be beat out of us by the mainstream medical community.
If only it were that easy, right?
Really? So can we talk about the detox element of the brain and how important it is to get good sleep when you're going through the process of killing bugs in your brain, right? Because you are going to have to detox. You are going to have to, you know, get these now dead bugs out of your brain. And how do you do that? And can you do that without getting deep sleep?
You know, I recently listened to a lecture by a neurophysiologist who's not a clinician, and she was talking a lot about the importance of sleep. We, as you know, don't really understand what happens during sleep, which is a third of our life. But there are some ideas, and one of them is that your brain detoxes during that time. And so the ideas are that we have activation of what's called our glymphatic system. So our lymph nodes are in our limbs, and then glymph nodes are in our brain. So it's a similar process, but it's affecting the brain, where it's draining the brain from toxic products. And according to this researcher, that during nighttime, that system is activated for about 6 to 8 hours. So if you're not getting that amount of sleep, you're not truly detoxing your brain properly. And you need to imagine it as if your or that glymphatic system operates like waterfall. With that amount of pressure, you're trying to detox your brain, and you're basically, if you're not getting that detoxification every night or almost every night, I know that, you know, people get sleep deprived for various reasons. They have kids, they have work, they have insomnia, you know, different things. But you do need to have that happen in order to detox your brain. Otherwise, you know, you're going to be encephalopathic in some form or another until that system starts activating.
So one of the things we often talk about with folks in the community is this wired but tired, tired but wired experience where, you know, they're exhausted, but when it's time to go to bed, they just can't fall asleep, and in some cases they're full of energy and bouncing on their bed. One of our past guests, Theora DeBronte, had put up a really famous video where she was, you know, getting ready for bed, and then she, you know, and then she was jumping on her bed because she was just, you know, she had all this energy. So can you explain, if you know, what this tired but wired experience is, and is that neurological?
So, I mean, it seems like they have issues with their neurotransmitters, right? So Mel puts you to bed and Sarah wakes you up, melatonin, serotonin. So it probably is a dysfunction of neurotransmitters.
Okay, now let's talk about the HPA axis, because this is another issue that we deal with here in the Lyme community on a pretty regular basis. And I've actually benefited from understanding that system. Can you talk about the HPA axis and how you talked a little bit about that, which wakes us up because of cortisol as a part of that, but how our cortisol receptors could be negatively impacted and how that could result in a rush of adrenaline in our system and put us into the fight or flight presentation, or the sympathetic expression of our nervous system.
Right. So, I mean, that is an activation of our sympathetic nervous system, where, as you said, it's the flight or fight response, where in order to heal, rest, and digest, you need activation of your parasympathetic nervous system. And part of that, right, it's that constant loop where you're, as you said, cortisol, adrenaline, it's kind of overactive. And that is part of your autonomic nervous system as well, which we talked about earlier, where you don't have the proper differentiation between when do you need to have some adrenaline, some energy, and when do you need to rest. And it is, I mean, I would almost think of it as pods. You know, how people, it's like your body is just not functioning properly. You have increased heart rate when you're standing up and you don't feel good. And so the same thing here, you have dysregulation of your autonomic nervous system. It doesn't know what it's doing. And the autonomic, so those patients have elevated blood pressure for no reason, or elevated heart rate for no reason. So it's the same exact mechanism of action that I'm thinking that's causing this issue as well.
Another question I wanted to talk, or another area I wanted to talk with you about, is the brain as an energy hog, right? And the shortcuts that the brain uses because of all of the energy that it uses. And specifically, I'd like you to address neuroplasticity and neural pathways, excuse me, and how the bugs in our brain are impacting our neural pathways, and how they may, in fact, be using our neuroplasticity against us.
Wow. And you've discussed this with other clinicians?
I don't know that I have, but because you're so smart, I figured I'd want to give you.
No, it's interesting because I haven't heard other people talk about the use of neuroplasticity against us. I'm happy to talk about neuroplasticity, which I think is a big part of, you know, neurology, and in different aspects, in Lyme and autoimmune for sure, but in different aspects, like in patients who have strokes and brain injuries and all of this. Our understanding of neuroplasticity in the past was that basically kids have neuroplasticity. But then there is literature coming out to say, and this is not new, that's saying, look, 80-year-old people have neuroplasticity. Everybody has neuroplasticity. How do you activate it? And maybe even adults have a better way of using neuroplasticity than kids, because they're able to be more disciplined and they have the insight and they know what the end goal is. So I like the idea of using neuroplasticity. I don't know in terms of the bugs are using, I mean, the way that the bugs are affecting the neural pathways is clear. It's the same thing as the inflammation, it's the autoimmune, it's the bugs actually invading portions of the brain and microscopically, as we talked about. So all of that would change our neural pathways. But how do we use neuroplasticity to address that, right? So we understand that, for example, that this part of the brain, and this is common knowledge, this part of the brain makes your arm move. And if the bugs affect this part of the brain, your arm is going to move less. So how do we use nearby cells so then they take over the function, because this part of the brain is actually not affected by the bugs or inflammation. So we want to use the nearby cells that are functioning properly and allow them to kind of take over that function. And so that's how neuroplasticity works in general. How do people use it in Lyme world? I think is by using cognitive behavioral therapy. and mindfulness, which some patients are very successful with. And I want to preface it by saying that I believe that every patient can do it. And on my other thing is, it is hard to do. And my third thing is, it's hard for everyone. So even the person who's doing it successfully, it is still hard and it's a lot of work because it's causing you have to be concentrating on this specific task more percentage of time than you're not concentrating on it. And that's how it's going to work. And this is a huge topic. It's looked at for different disease processes, not just neurolyme. It's looked at for cancer treatment. It's looked for psychiatric, especially if patients have insight into their medical condition. I think it's a very important aspect of it. I think that if you're going to someone to kind of start learning, it's great because they'll give you the tools, but the real work is what you do at home 24/7, when you're by yourself, when you're with your friend, all the time, as much time as you can spend to kind of retrain your brain to stop thinking about the loop, the negative loop, the fact that everything is not going my way. I want everything that I've had 5 years ago, and where is it now? Kind of all of those things, thoughts that I call, they're not good thoughts or bad thoughts, they're beneficial thoughts or detrimental thoughts. Is the thought that you're thinking about benefiting you? If it is, or making you feel good? If it is, then continue with that. If it's not, try to change it.
So let's build this out a little bit more, because I think there's two different pieces to this. And so one of the things that makes us a dominant species is that we are adaptive, right? That we have epigenetics and we have neuroplasticity. Our bodies and our brains are changeable, and as a result, as there are changes in our environment, we are able to physically change and we can adapt to those changes, which is why we survived and most other sapiens have not, right? And that's a very positive thing. But then, of course, we have this other piece, which is our neuroplasticity. I'm arguing can be altered so that it doesn't serve us, right? And I think there's two pieces to that. One piece to that is we have neural pathways that are triggering thoughts and feelings and ultimately actions that are not serving us, right? And some of those pathways are changed based on the way we're treated by our doctors, for example, or the way we're treated by our family members who don't believe us, or our friends who don't believe us, or all those other kinds of losses. We have those neural pathways that are changing as a result of those negative experiences. But we've also had people on the podcast share with us that despite resolving the physiological elements of Lyme disease, they continued to be symptomatic until they went through a neural retraining, until they used, for example, DNRS. We recently did a really powerful podcast with Rachel Leland and her mom, Dorothy, based on the book that they had written together. And what Rachel told us was that she continued to be symptomatic until she went through the neural retraining. So my question to you is, on the symptomatic piece, or the physiological symptoms, what's happening in the brain? What is the bugs doing to the brain so that in some cases, like Rachel Leland, she continued to be symptomatic even though the bugs had been killed and the treatment had been effective, but she continued to be symptomatic until she went through the neural retraining?
I think what was happening is that she was using the old pathways, right? And those old pathways were, let's say, pain pathway. I'm just saying, I don't know this case, but those pain pathways, and every time, as an example, I'll just bring up like a facetious example where every time I pick up a cup, I'm using the pain pathway as well. So I need to, as you said, retrain to decide or train your nerves to say, look, every time I pick up a cup, I'm going to think of yellow butterfly, instead of think of pain. And so that's the way I believe this works. Again, I'm not sure that we know 100% why some patients are more successful with it or less successful with it. I think a lot of it has to do with concentration, realizing, having a lot of insight, being dedicated to the process, believing in the process as well, which a lot of times, as you said, is really hard to do because you don't resonate with something that's being told to you, or you've had a lot of negative experiences. You know, all of these things fall into place. But as you said, this system is made for us to be adaptable. So, and I understand what you're saying. And I actually have not had this discussion with other people as well. Interestingly, I don't bring up this part of treatment with every patient. I do wait for them to bring it up a lot of times because then I think that they're open to receiving this message. Because if I bring it up when they are in a very bad place, I feel like that can trigger sort of a, you know, PTSD moment where I'm telling you, this is all in your brain, and you just need to fix your brain on your own so that you could feel better. That's not exactly what I'm talking about. I think, again, it's a combination. You treat the bugs. When you start seeing some benefit, use that momentum to start using this dynamic neural retraining at the same time. And I think that would bring you more success because here you're already seeing some benefit. So what it's sort of like, you know, starting to do physical therapy. You can't start physical therapy on a broken leg, right? You need to let the leg heal a little bit, but then in order to get it back fully functioning, you need to put some additional work by exercising, strengthening the local muscles, maybe retraining other muscles to take over because that muscle is not working properly. It's exactly the same thing that we're talking about.
So can you talk to us about belief and the importance of belief on the healing journey, and how does the brain ultimately create pathways that allow us to either believe something is going to work or it's not going to work?
Well, I think it's not about how the brain will believe. It's how you will believe. So you
Okay.
need to have an emotion, right? You need to have an emotion that it's if somebody is sick and not feeling well, having a terrible day, and I'm going to them and I'm like, you need to say to yourself, I'm healthy. That person gonna believe me?
Of course not.
They're not going to believe me because they've had 30 days where they felt crappy and telling themselves, I'm healthy, that's not believable. It's not bringing up the emotion that is healing. I actually had this discussion today with someone. In that particular case, when you're in a bad place like that, all you need to do is reach for a better feeling thought. What is that, right? That thought could be, I had a really good cup of coffee today. Completely facetious compared to you feeling healthy and wanting to, you know, get married or go back to work or have kids or whatever. In comparison, it's nothing, right? Having a good cup of coffee. But that thought is a better feeling thought than I'm never going to get out of this wheelchair. Agreed? Does
Agreed.
everyone agree with that? Okay. So once you start reaching for those, you need to identify that you're having a bad thought, right? Or that you're having a thought that's making you feel bad. That's the right way. And once you identify that you're in that loop of having those thoughts that are not making you feel good, then you have to reach for a better feeling thought. And the more you're able to do that, then you're going to be at a vibrational frequency, let's put it that way, of I had a good cup of coffee today. When that's your baseline, then you can reach for an even better thought. I think I had a good doctor's appointment today. That's a better thought, right? Closer to your goals. So then when you get to that vibrational frequency, then you can say, oh, I was able to walk today for 1 block when I wasn't able to do that for 5 years. So, and that's how you slowly make it more believable to yourself, because you're not going to be able to have neuroplasticity from 0 to 60. That is not possible. And even if it is possible for some patients, which is quote unquote a fluke, it's not sustainable. But what I'm saying, kind of retraining like that, going from a cup of coffee to I had a good visit to now look, I could walk for a block further, I'm planning a trip abroad, things like that. And still, I'm not talking about like, I am the same I was 10 years ago, right? I'm not going into that because that's kind of talking from a place of lack. So you're moving to these vibrational frequencies that are believable to you and that feel good. And that's how you create neuroplasticity that is sustainable and believable and long lasting.
All right. So now, are you defining frequencies, vibrational frequencies differently than neural pathways, or are they the same?
I mean, I think that I'm using that term interchangeably.
Okay, and I would too. I'm not trying to cross-examine you. I'm just asking because
Yeah.
I would use them the same as well. And by the way, I think this is a brilliant. You're really brilliantly describing this. So, we began by mapping the central nervous system of triggering thoughts, feelings, and actions. Right. We talked about that piece of it, and one of the personal development experts that I studied with he talked about a tool that he calls neural sculpting. And what he argues is that there's a psychocybernetic loop of beliefs, thoughts, feelings, actions, results, which then reinforce our beliefs. And that's where we're in our brain, our beliefs are triggering all of these automatically triggering all of these other actions. And his argument is that you should go through a process very much like the one you described, although he was looking at the loop differently. And his position is that all of our thoughts are automatically triggered by our beliefs. All of our feelings are triggered by our thoughts. And once we get to a place where we don't feel good, that's essentially our onboard diagnostic system telling us that our thoughts and our beliefs are not accurate. And we have to walk back to the thought and say, all right, what was the thought that I had that triggered this feeling that doesn't feel good? And then you walk it back one more step and you now ask, what did I have to believe in order to have triggered the thought that I had that again caused me to have this feeling that was bad? And now because our onboard diagnostic system is telling us that it is not true, that either the opposite of some form of the opposite of that belief is what the truth is. And once we show that to our brain, that's when our neuroplasticity begins to make the changes in our neural pathways that stop us from having those negative thoughts, feelings, and of course, then it takes us to the negative action. So give me a reaction, because it sounds very much like what you were just describing to the David Bayer perspective.
I like what you said. I think what I was talking about is I gave you a shortcut.
Yes.
Because I didn't analyze where's this thought coming from. And I do like the use of that, but I don't think you need to use it every single time. I think if you use the shortcut and it works, just do it. But if you can't get that thought out of your head, right? If it's in a loop, like I'm going to be in this chair for the rest of my life type of thing, and it's not going away, then I would definitely do the work of kind of self-reflecting and figure out. And there's many different tools. And the reason why there's many different tools is because different things, people learn different ways, and different options resonate with different people. But there's ways to do that where you kind of go back and say, well, where is this coming from? what's the belief, what am I really scared of, what am I really upset about, and where is this coming from, and then kind of try to figure it out and replay it in your mind. Either have that conversation with a different person or have a different outcome to that conversation. There's different ways of doing it that people talk about, and you could try different things. But what I was saying, it's a shortcut. This would be something that if it's not going away, definitely use this system. And that's probably better to use for like big things. You know, someone was mean to you on the bus, just like think about the good cup of coffee your wife made you, you know, at 7 a.m. But if it's something like big, where, you know, it's related to health or big issues that are kind of there and not going away and you've had them for years, probably good to do the work as well.
All right, so I want to ask you about timing, and I know Matt is anxious to ask you a question. We've had you for 2 hours, so we know we're going to have to let you go sometime soon. This could be an all-night conversation for two Lyme geeks like us. But I want to talk to you about timing of neural retraining, because there have been some guests where we've argued, hey, we should be focusing on neural retraining right away. And what they've said to us is, look, I was so sick, I had so much going on, I really couldn't focus on it then. But it almost sounds to us like, and we've had others, others have said, look, the neural retraining really has to be during sort of the rehabilitation phase, after I've gotten through, you know, the battle, and after I've finished treating, you know, with herbs and antibiotics and other tools to kill the bugs. That's when we should be doing the neural retraining. So what is your position? Is that really something that should be an element of rehabilitation rather than an element of prehabilitation, or do you think that should be something else?
I think my opinion is in the middle. I think that when you start getting on the road of recovery, that's when you use it. I don't think you need to finish treatment in order to start it.
Okay.
And I don't generally use it at the onset of treatment unless the patient brings it up themselves. And when they start seeing some results, that's a good time to start implementing, because you're basically on that, like get on that snowball effect. I'm feeling better. Things are going my way. And that's when you start kind of adding that in as well.
Thank you. I really love this conversation, and it is 2 hours, so we are going to wind down. Matt, are there any final questions that you have for the brilliant Dr. Frid?
I just want to know from the patient perspective. I mean, we know you're in New York City. We know you're in Manhattan. The question I have for you, and I think a lot of people listening are thinking, do you do telehealth? Because many people are all around the world, never mind the country, that listen to this podcast. And do you take insurance? Because I know we're going to get beat up if we don't ask those two questions.
Yes, I do telemedicine if the patient comes in for, like they want to become a patient of the practice. I do have them come into the office, which happens once every 6 months, and then we do a lot of follow-ups on Zoom. And in terms of insurance, I don't accept insurance. I actually don't accept too many patients either. I have a small practice. Because we deal with such complicated patients, they do require a lot of attention. So, but we do accept new patients. We don't accept insurance, and that's my my answer.
Well, Dr. Frid, you've been a fantastic guest. Matt and I had very high expectations for you when we were doing our pre-podcast preparation, and you've actually exceeded our, I don't want to speak for Matt, but certainly exceeded my
Yes.
expectations. This has been a really, really enjoyable interview, and we know our folks are going to really benefit from all that you taught us today. So thank you so much for the work you're doing, and thank you for dedicating your career to working with folks in the Lyme community.
Rich, Matt, thank you so much for having me on and for the work that you do educating the Lyme community and community in general. Amazing work. Thank you.
Thank you.